Okay, again, this is going to be a short video. It is also about IONM. Good. All right, let's get started. Equipment, you're supposed to do certain steps as a team member, and walking through those steps here with you. Equipment setup. We have some equipment like maybe electrodes, different varieties of electrodes, wires. And so you may want to set it up right before the patient enters the OR. You're supposed to be there like 30 minutes before the procedure starts. The patient is then being brought in the OR, intubated. You are going to place the electrodes and make sure you place them right so that you avoid artifacts. Do not place a lot of jelly on the skin. Skin is poor conductor. Okay. And then have the patient move to the array table. If you are like good enough with the physical fitness and something, then you may want to help people around because surgery is something that is a major event for the patient, also for people around to have the experience. Um, and then drapes are placed. Remember, you're placing your electrodes at first place, and then you're placing the drapes over that. Um, and so you may want to make sure the electrodes are not hanging out or the drape is not so long or cut it short. And then before the surgeon enters and have the patient start be operated or something, you may want to record baseline, okay? Baseline recordings. And once you do that, you will see the pattern where you can identify that it's normal, okay? You will notify, you will document about this to the surgeon and everyone around. Then the surgeon would simply go in and have his first go. Exposure, finally closing. So during the procedure, if you find abnormal signals, meaning there could be nerve irritation because of cut of eloquent tissue, and that should prompt you to tell to the surgeon so that the deficit is avoided at first place. Your main intention is to prevent these deficits post-operatively. Okay. And then you inform them. Then there is closing of the major surgery. And lastly, what you have seen on the monitor, you're simply going to communicate your findings, update the surgeon about the data. Once everything is done and sorted, you're slowly getting the electrodes removed and extubate the patient. So, regarding the equipment setup that I was talking about, you have your own stuff. So, make sure you get your stuff organized before you place those electrodes. So, this is a huge stuff. You don't have to carry. I'm sure will be shelves around where you can simply have a check on this kind of stuff. Here is a perfect example of poor electrodes being placed at a very poor pace. So if you are hurrying up, not being there at 30-minute interval, you may end up doing something like this. And this is really not a great picture. the electrodes, the electrical wires are simply hanging out, um, which can be danger to the patient, meaning like if the patient trips over, he would fall on the electrical wires, causing damage, because there is some current that is passing out. So we don't want to risk the patient with that. Have the electrodes placed at the right spot, with the proper pattern. Okay. This is also another example where you will be dealing with tons of wires that are multicolored, and each wire is like indicating a particular thing, which we will be seeing in a bit. This is also a very perfect picture I really like about. Everyone is dressed in the OT attire, and then there is one person who is constantly there monitoring the nerve health during this process. Literally, you may want IONM candidates in any surgery because there are nerves all across the body, and we do want to monitor these nerves to prevent post-operative deficits. Okay, interestingly enough, there is a pedicle screw sometimes for scoliosis. There is a pedicle being placed, and then sometimes the pedicle might want to be broadened out or maybe opened up. So during that process, we are recording the electrical activity by placing the electrodes over the pedicle. And this is called as pedicle screw stimulation. Okay, this is also a great picture where the electrical wires are inserted across in the nerves through the muscles to check for the conductivity and electrical activity. Masseter, orbicularis oculi, um, so many muscles that are innervated by so many nerves. We are basically focused at giving the feedback, prompting the surgeon to prevent further damage. And this gives the surgeon real time feedback at that particular time. So, your job is to simply tweak in between the surgery if there is a damage that you see. So, clearly, it's about communication, being clear on conveying the information at the right time. The purpose of IONM is to reduce the incidence of iatrogenic injuries, meaning it's the surgeon related injuries, the physician related injuries. Uh, and this is to randomly induce neurologic injuries. We, for example, any high risk surgeries, there is a complication added to that. In fact, it is an invasive surgery. So Even a small cut can cost something very big. For that purpose, our IONM team is there to prevent this. What is happening if there is no IONM candidates around and simply the surgeon is removing the tumor surgically? There is increased risk of deficits, like I said in my earlier video. So, if there is IONM, good patient mortality, good morbidity, good care, reduced deficits, reduced hospital stay, reduced cost, and reduced insurance burden. Everything is planned and scheduled well. There are numerous surgeries that may want to utilize these facilities, and no hospital is short of this. In fact, there are private companies recruiting, demanding for jobs like this. So it's very important. Same thing, I'm repeating. There is improved patient outcome. Surgical outcome is the best. There will be no deficits, very safe. And how are you able to say that? You are literally monitoring the nerve activity, preventing the deficits. Irrigation, warm irrigation, cold irrigation, mechanical trauma, or impending nerve injury. Beneath that, the cut is gone, high cut, and it's penetrating. Then there is a nerve around that could have been damaged. So it can be very well detected. There will be a spot on for you on the monitor, and you are the one who is going to interpret this deficit, intervene the procedure, and give a feedback according to what you see. So this is like a great opportunity for you to take the lead. You are measuring two kinds of signals here. No doubt it's electrical signals, but you are measuring spontaneous activity and you are elicited or evoked activities. All this is from the brain, spinal cord, peripheral nervous system, muscle groups. All in all, you're monitoring the motor unit during the procedure. Now, there are complex cases. For example, let's say aneurysm or maybe a thyroid tumor. IONM is the one who prevents the neurologic impairment from progressing further. Okay, again, the same thing I've said just now is being there on the slide. So, all we are doing is promoting the surgical outcomes to a better perspective from patient's point of view and also from the surgeon, so that the surgeon is able to take over the entire team's credit. Okay. However, it's not simply that a surgeon is behind the surgery. There is this whole team that is the taking an account on the credits of this success. So, if you think of it, we are not simply posing something good to the doctors. Rather, we are posing something good to the entire team. So that's why team-based approaches go a long way. Here is a very good example. IONM as a team guides this to prevent the surgical complications. You're literally intertwining the procedure because you want to provide your feedback, and your feedback is very essential. It assesses how likely the surgery could turn out to be a success, how likely the person is not having to undergo sensory deficits following high risk surgeries. So, our main goal is to cut down the post op complications so that the patients are not overwhelmed. So, these are like multiple abbreviations on the neural pathways. You can simply go through these. We will be going in detail. So again, we are recording two electrical activities. One is the spontaneous and the other is the evoked, that is the elicited one. Now, this is a picture that depicts the placement of electrodes. And here you're going to see the electrical activity on particular sites. All right. So motor evoked potentials are two types. One is the transcranial, other is the magnetic one, electrical and magnetic. Motor evoked potentials, we will be knowing the motor pathways, that is the descending pathways, where the first order neurons, second order neurons, and third order neurons are involved. And then you are going to record the electrical activities. So there are spikes and amplitudes, bursts of electrical activity that you should be documenting. Electromyography. I'm sure you must have heard of this. There are several clinics with this particular device. If you don't know what it is, you may just think of it as a part of treatment, and that's it. So it's pretty good. Okay, electromyography is recorded from the distal muscles. The activity is being recorded with the nerve. You are seeing the nerve and the muscle fiber. Okay, so in the cortex, anterior spinal cord, locomotor neurons, neuromuscular junction, and muscle fiber. Okay, so this is the pathway. Here also there are two types. One is the spontaneous and this triggered. Spontaneous is just recording, which you can see on the right, and thermal irritation you can make out. You can make out any mechanical injury or anything like that. But the trigger one, on contrast, is something different. Here you are going to use monopolar electrodes to identify the nerve tissue. Okay, look at this picture. It is a great picture. You can derive key components of what we are doing and how we are interpreting. Triggered electromyography is recorded from the distal muscles. Activity recorded is associated with nerve, nerve root, and pedicle screw electrical stimulation. Okay, so you see this electrode is being penetrated. across a pedicle screw and then you're stimulating it. Why? Because there can be associated nerves around, and that can be shown up to you as an a pattern. So each time you're stimulating, you're not simply getting the electrical activity where you're having the latency, amplitude, and things like that. That's all for now. I hope you really enjoy my video, and I will see you soon. Thank you.